Yes, we are live, so I think we can. Good evening, friends. Today we have the next episode of IGMPO Talks. As you all are aware now, we invite experts from various fields from all over India as well as all over the globe for the benefit of students of DM and DM medical oncology. Today we have with us Dr. Satya Prakash Yadav, who is a very senior medical oncologist and who is going to talk with us about management of neuroblastoma, advances, and the Indian data. Over to you, Dr. Yadav. As everybody is aware, please be muted. It disturbs the talk. If your mic is on, I would be forced to remove you from the talk. You can follow the rest of the talk over the YouTube stream. We are live on that. And please keep putting your questions in the chat box. We'll take the questions one by one once the talk is over. Thank you very much for your patient listening, and over to you, Dr. Yadav.
Thank you, Dr. Padmaj, for the kind invitation. And I'm pleased to be here and talking to all the trainees who are logged in and through the YouTube. So the topic given to me was I have to speak on neuroblastoma. And I thought that this is a very, very interesting topic for medical oncologists because neuroblastoma is the second commonest solid tumor you see in children. And it's the commonest tumor in children less than 5 years of age. So if a child comes who is like 1 year or 2 year old and has some sort of a tumor in abdomen or anywhere else, the commonest thing which should come in your mind that could it be neuroblastoma, because that's the commonest thing you see in such young children. And neuroblastoma is an enigma in a sense that it can go away without treatment. Spontaneous regression is known, and it may not respond to anything, and it may be very, very aggressive also. So it's a range spectrum of how it is. And through my talk, I will try to unsolve this mystery and try to simplify that which children are likely to do very well and which are the children who need aggressive treatment. We can stratify them. So the few slides in my talk have been taken from Dr. Shakil Modak's presentation from Mount Sloan Kettering Center in New York. And I'm very thankful to him. And I've used those slides in my slides as well. That's a disclosure. Then what we will discuss is that I'll introduce the topic and then take you through the risk factors, and then INRG classification, that is International Neuroblastoma Risk Groups, and then discuss a little bit about low risk neuroblastoma, how do we manage, intermediate risk, high risk, and few slides about relapsed refractory neuroblastoma, and then a couple of slides about Indian data. So first, the origin of this tumor. So it's a neural crest from where, like in an embryo, there is neural tube, and there are neural crest cells from which various neuronal cells arise, like sympathetic chain, parasympathetic chain, melanocytes, your adrenal cells, your neuroendocrine cells. So if something goes wrong somewhere in this development and differentiation, and depending on what that cell was going to be, the tumors are of that area. So it can be a schwannoma, it can be a pheochromocytoma, it can be a neuroendocrine tumors, it can be melanoma, it can be neuroblastoma, which basically these are the cells which were going to form the sympathetic neuron. And the distribution of neuroblastoma is all along the sympathetic chain. So it's paravertebral tumor that you will see, or it may arise from the adrenal gland where the sympathetic neurons are present. So that's the origin of this tumor. And this is a very basic slide on staging. So International Neuroblastoma Staging System, we all are aware that's INSS, which has been used for many decades. So in this, if you see this picture carefully, there's a small child. In stage 1, typical tumor which is small, like suprarenal mass might be there with a speck of calcification on CT scan, and urinary catecholamines would be increased if you check for them. And so stage 1 neuroblastoma is usually fully resectable, and that's easy to treat. Stage 2 also is a little bit bigger but hasn't spread to the regional areas, and it's still fully resectable. So stage 1 and stage 2 are easily resectable, easy to treat. Stage 3 tumor, as you see that it is a bigger tumor, it is crossing the midlines, and it may involve the local lymph nodes. It is usually retroperitoneal extent, would be invading the vessels like aorta, would be around IVC and others, and it's difficult to get a clear resection. So it's incomplete resection is common, or surgically it's not fully resectable in stage 3. And stage 4, as you see this child, this is the aggressive form of neuroblastoma, which has spread everywhere. So you have a primary tumor, which is huge. You may have liver metastasis, you may have bone metastasis, you may have bone marrow involvement, and you can have lymph nodes and other areas are involved. Then there is stage 4S. And in stage 4S, this is typically seen in infants or children less than 18 months of age. And here, this has very good prognosis and spontaneous regressions are known. So it is different from stage 4, which is very bad. Stage 4S is very good. And how you differentiate between the two is that the primary tumor is usually small in stage 4S. So when you do a CT and look at the primary tumor, it would be at best stage 1 or stage 2, not stage 3. And it usually does not involve bones. So bones are spared. When you do a PET CT scan, there will be no bony involvement in stage 4S. And typically skin may be involved here, and bone marrow involvement is less than 20%. So you don't have a lot of marrow infiltration in stage 4S. It may be involved, but it will be less as compared to a stage 4 where it can be florid involvement of the marrow. So now we move to the next slide. And as I told you, this is a tumor arising from a neuroblast. And these neuroblasts differentiate into ganglionic cells of sympathetic chain. So in this maturation process or differentiation process, if something goes wrong at whatever step, it can lead to proliferation at that particular step without differentiation to normal cells, which are sympathetic ganglionic cells. So if it's totally undifferentiated tumor, then it is called undifferentiated neuroblastoma, as shown in the bottom in the left-hand side. And on histopathology, this is typically called small blue round cell tumor. So when you see small blue round cell tumor on histopathology, neuroblastoma is always a differential diagnosis. Other differentials can be Ewing sarcoma, can be lymphoma, can be like if it's an eye, it's retinoblastoma. In the brain, it can be medulloblastoma. So there are different diagnosis differentials of small blue round cell tumor in children. So you must keep neuroblastoma as one of the differentials, especially if it's an abdominal tumor or somewhere in the thoracic paravertebral region. Then if it differentiates a little bit, it could be showing pseudo rosette formation in the histopathology. And this is a classical neuroblastoma where you don't have doubt, and it may be synaptophysin positive on immunohistochemistry and NSC positive as well. So here you don't have a lot of difficulty in diagnosing on histopathology. A pseudo rosette is like a whorl formation without a vessel in the center. There is when you have a vessel, it is a true rosette, which then as it differentiates further, it may look like a ganglionic cells, and it's called ganglioneuroma, that tumor. Or if there is still some elements of neuroblastoma, then it can be ganglioneuroblastoma. So it can range from neuroblastoma undifferentiated to little bit differentiated neuroblastoma to ganglioneuroblastoma to ganglioneuroma. And ganglioneuroma and ganglioneuroblastoma have very favorable outcomes. They do very well. Almost everybody is cured. So histology is very, very important. What you see, and that would decide the outcome of the child. So coming to another important aspect of management of neuroblastoma is MYC oncogene. So as you know, that MYC oncogene, it was first picked up in birds, in avian, and it in birds it is called VMYC, and it's a myelocytomatosis virus which causes this oncogene in birds. In humans, its cognate is CMYC, which is commonly involved in pathogenesis of Burkitt's lymphoma or diffuse large B-cell lymphoma. CMYC is seen there. And NMYC is a homologous sequence of CMYC, and it's typically seen in neuroblastoma cells. And this gives power and aggressiveness to the neuroblastoma cells. LMYC is seen in the squamous cell, large cell, in lung cancer, etc. So this particular NMYC, it activates, these are the transcription factors which activate MADMAX pathway and leads to cellular proliferation and leads to increased aggressiveness of the tumor. So NMYC, basically it arises from chromosome 2p24, and these are double minutes, and the amplification of this is present in cancer cells. So you find many copies of NMYC. So that is called NMYC amplification, and that is typically present in neuroblastoma cells. Approximately 25% of neuroblastoma tumors have NMYC amplification, and it should be tested because this has poor prognosis. The children who have NMYC amplification do poorly. This, as you see in this slide, those who have NMYC not amplified, their outcomes are almost like 80 to 90%, and those who have NMYC amplified have very poor outcomes, around 10%. So that's the significance of NMYC. So whenever you have a neuroblastoma, you have taken a biopsy. In that biopsy, ask for NMYC amplification test, and that would tell you about the prognosis of the child. If you look at overall picture of neuroblastomas, around 40% of neuroblastomas are fairly favorable. They tend to do well. Like, the best thing is about this tumor is that spontaneous regression is well known in very young children, especially infants with stage 4S, or newborns born with an antenatal tumor detected on ultrasound in mother's womb. So these tend to differentiate into normal ganglionic cells and regress in size. Other is spontaneous maturation. So you may have neuroblastoma, but it matures into a ganglioneuroma over a period of time. And you don't have to do much, except maybe surgery may be required to remove it. So these almost 98, 99, or 100% is the cure rate of these favorable neuroblastomas. Then comes the aggressive neuroblastomas, and that's where we need to give chemotherapy or more than chemotherapy, like transplants and radiation, etc. So here, NMYC, as I've highlighted in my previous slide, is the main driving force in nearly 25% of the patients, which leads to aggressive nature of this tumor, and it tends to metastasize. And those who are NMYC negative, but their histopathology is unfavorable, they have undifferentiated neuroblastoma, and they usually have 1P deletion or 11q aberration on cytogenetics, and they tend to be very aggressive tumors as well. So now I'm going to take you through this busy slide. It's difficult to read, but the main thing which I want to highlight is that this is a data of around 8,000 children treated across the globe, across various centers for neuroblastoma. And this data was combined by International Neuroblastoma Risk Group to stratify the patients to see which ones are low risk, which one are high risk, which one are intermediate risk, and to predict the prognosis. So if you look at the part A, which is on the left upper corner, this is the data of 8,000 patients of neuroblastoma who were treated, and overall outcomes were around, overall survival was 70% and event-free survival of 65%. So out of 8,000, nearly 70,000 have survived the treatment. Okay. So if you look at the impact of stage, so stage 1, 2, 3, and stage 4S, they have very good outcomes, more than 90% overall survival. But stage 4 has just about 40% survival. That's in the red or dark maroon box. So that's stage 4. So straight away you know that if a child has stage 4 neuroblastoma, his outcome is likely to be bad. But if it is anything other than that, outcome is going to be good. So staging is very important and very powerful prognostic marker. Then in those who are in stage 1, 2, 3 and stage 4S, if you look at the histopathology, if the histopathology is showing ganglioneuroma or ganglioneuroblastoma, that means it is already differentiating into normal ganglionic cells, then they tend to do very, very well. 98 to 99% survive with just surgery alone. So these patients do very well. That's in blue in the A block. And if you see those who don't have this ganglioneuroma or ganglioneuroblastoma, in them NMIC is important. If NMIC is amplified, it is very bad outcome, and NMIC non-amplified, they do very well. So if you are stage 4 and if you have NMIC amplification, you are likely to do badly. But if these two are absent, you are likely to do better. So that's the key message of group A. Now coming to group B. So group B is further subclassification of NMIC non-amplified group, stage 1, 2, 3 and stage 4S. So when in this group, if NMIC is non-amplified, how they do? So they do very well, except in stage 4S, that is the extreme right hand side. If you see, you can divide stage 4S into two groups. These are NMIC non-amplified, and in them you should look for 11q aberration. If 11q aberration is present, they have very poor outcome and become high risk, red. And if that is absent, they are blue. Almost everybody is cured. So in stage 4S, if NMIC is non-amplified, 11q aberration is not present, almost everybody is cured. You don't have to even treat or give any treatment to them. Okay. Now coming to part C. So that is on the left hand side below A. In this, there is the analysis of NMIC amplified. Almost they do very badly. So whenever NMIC is amplified, they don't do very well. So only thing which makes a difference is LDH levels. So you should order LDH, and if it's more than 547, then there is a cutoff called 550 or 540. They tend to do 567. Sorry. If it's more than that, they do poorly. If it's less than that, they do slightly better. So that is one prognostic marker in neuroblastoma. You should do LDH as well. Then coming to part D. So this is the stage 4 patients. We know the stage 4 patients do poorly, metastatic neuroblastoma. But in this, is there a subset which may do fine? Yes. Infants. Children who are less than 18 months of age, that's in yellow box in the group D. If you see the yellow thing, that's the children less than 18 months. So they tend to do better as compared to those who are more than 18 months. Those who are more than 18 months, they have uniformly poor outcome. But less than 18 months, and if NMIC is non-amplified, then they can have very good prognosis. So even in stage 4, if you are less than 18 months and NMIC is not amplified, your prognosis could be very good, almost 80% plus have overall survival. So now let's move to the next slide. So based on that previous slide, that data of 8,000 neuroblastoma kids, now the INRG group has come with this classification of low risk, intermediate, and high risk neuroblastoma. And based on that, we can plan the treatment of the children. So it's very important to understand this particular concept of risk stratification neuroblastoma. Once you have done the risk stratification, it is easy to decide how to treat. So let's come to this. So in this, if you see L1 is a localized neuroblastoma, which is fully resectable. L2 is localized neuroblastoma, which is unresectable, which was previously stage 3. And M is metastatic neuroblastoma. And MS is a special 4S, similar to what we had 4S in the INSS staging system. MS is in the INRG. Now, if you look at these categories, so there is a special category in localized tumor, where the histopathology is very important, as I've shown in the previous slide, that if you have ganglioneuroma or ganglioneuroblastoma, which indicates that it is already differentiated or differentiating towards normal ganglionic cells, they have very low risk of relapse. They do very well. They have very good prognosis. In such children, just surgery alone may be sufficient. You don't have to do anything more than that. So histopathology, you've done a biopsy, histopathologist shows this, you tell the parents child is going to do very well and just do surgery. And surgery, you don't need clear margins. You just do debulking, because if some big vessels are there, or it's a paravertebral mass, so, or it's some organ is very closely nearby. So don't try to cause deficits, because that would affect the quality of life of that child. So just do debulking, and if the tumor grows again, it can be resected again. So the prognosis is very good. Now come to the remaining L1 and L2 patients who don't have this ganglioneuroma or ganglioneuroblastoma. So in these children, you should look for NMIC. If NMIC is amplified, it is poor, it becomes very high risk, and they have very high chance of relapse. But if NMIC is not amplified, they are either low risk or intermediate risk. So who is intermediate risk? Intermediate risk in the less than 18 months, if it's 11q aberration is present, it is intermediate risk. And in more than 18 months, if there is poorly undifferentiated neuroblastoma, then it becomes intermediate risk. Okay, now, or 11q aberration also would make it more than 18 months. In metastatic, as I have told you previously, that if NMIC is amplified, it is bad prognosis, or more than 18 months is bad prognosis. These are high-risk patients. But if you're less than 18 months and NMIC is not amplified and you have hyperdiploidy, it is very low risk of relapse. Such children can do excellent. And if hyperdiploidy is not present, then it is intermediate risk, which would need some chemotherapy. Stage 4S, these are children less than 18 months who have skin involvement, and as I've already told you, that bone involvement is not there, marrow is limited involvement, and primary tumor is small. So this is MS. If NMIC is not amplified, they do very well, but if NMIC is amplified, have poor prognosis. One other thing is you have to look for 11q aberration. If it's present, they become high risk. So now you understood the risk stratification. So the approach to neuroblastoma in today's age is to reduce therapy where possible. So don't overtreat these children. If the child is low risk in the risk stratification, then almost 98% chance that he will be cured. So to such a child, if you offer chemotherapy, radiotherapy, it's not a good idea, because it would have a lot of long-term side effects. Patients with relapse can also be salvaged if you achieve a remission again. So if a child of neuroblastoma has relapsed and you can again control the disease, get a second remission, you can again offer some lot of treatments and try to salvage them, and their life can be saved. Surveillance is important. After finishing the treatment, keep on doing surveillance. And early pickup of relapse, you can offer some local treatment for that particular one spot of relapse and try to give a longer life. Tailoring of therapy as per the risk stratification is important. So as I've told you that in stage 1 and stage 2, minimal therapy is the key. So once the tumor has been fully resected, unless it is NMIC amplified, you don't need to do much. Just surgery alone is sufficient, and survival is close to 98%, as I've told you. So minimal therapy, just surgery would be required in majority of stage 1 and stage 2 or localized tumors, as I've told you. For stage 4 patients, if they're more than 1 year of age, then they tend to do poorly. These are high-risk patients. And if you see over a period of time, gradually the results have improved. Previously, they were about 10%, then they have improved about 30% in the 90s. One of the new drugs which has come is cis-retinoic acid. Cis-retinoic acid is a congener of vitamin A, which differentiates neuroblastoma cells into normal ganglionic cells or normal neuronal cells. So this was added to the treatment of high-risk neuroblastomas, and this is the work of Catherine Mathe from US. So this was a randomized controlled trial in which all children with high-risk neuroblastoma who have poor outcome, they were offered After initial chemotherapy, surgery, and radiotherapy, they were randomized to receive autologous stem cell transplant versus chemotherapy. And then it was a double randomization. There was second randomization where they gave cis retinoic acid and they did not give cis retinoic acid. So there were 4 groups. In one group, which got everything, got autologous transplant and got cis retinoic acid, that's the top yellow curve, the survival improved to nearly 45%. And the bottom group is chemotherapy alone, no cis-retinoic acid, no autologous stem cell transplant. The survival remained at about 15 to 20%. So based on this study, it became a standard of care that the children who have high-risk neuroblastoma, they should be offered intensive chemotherapy, reduce the disease, do a surgical debulking, give them local radiotherapy, and get them in very good partial remission or almost complete remission, and then do an autologous transplant. And after transplant, give them differentiation therapy with cis-retinoic acid orally 2 weeks on, 2 weeks off for about 6 months. And with this, you can expect 40% of children can be cured. Then came another new treatment for high-risk neuroblastoma. So now we have a monoclonal antibody which can target GD2 protein on the neuroblastoma. So GD2 protein is present on all neuroblastoma cells, and this particular monoclonal antibody is called dinutuximab, is the commercial name, and this can kill the tumor effectively. So this was added to the standard of care of high-risk neuroblastoma. So you have chemotherapy, you have surgery, you have radiotherapy, you have autologous stem cell transplant, you give cis-retinoic acid, and you also give anti-GD2 therapy injections. And with this, wow, this NEJM paper showed that overall survival improved to 80% from 50%, and event-free survival improved from 40% to 66%, which is very good. So a huge jump in the survival. So this was a great discovery. But unfortunately, dinutuximab is still not approved, is not available in India. Even we can't import it because the US company has blocked its import in India. So we are trying our level best to make this drug available in India in the near future, and I think it would be available soon, and that would really improve the outcome of high-risk neuroblastomas in India. So if you look at this slide, which shows you essentially 3 groups. So stage 1, 2, 3 and stage 4S is a separate group. They tend to do better. And stage 4 is the bad group. They tend to do poorly. So if you look in the center part, so these in the center part is the high-risk neuroblastoma. So either NMIC amplified, any stage, or more than 18 months, stage 4, with NMIC amplification or NMIC amplification, these are high-risk patients. So these patients should be treated very aggressively with multimodal therapy, as I've told you in the previous slide, and we can expect overall survival around 65%. In India, we expect around 40% because we don't have dinutuximab. If you remove those patients, and now these are the good patients we have. So in the stage 1, 2, 3 and stage 4S, if NMIC is not amplified, they tend to do very well. And if they have favorable histology, then surgery alone is the treatment. These are low-risk neuroblastoma patients, and they have survival more than 90%. And if you have stage 4 patient less than 18 months of age, and NMIC is not amplified, then they also have very good outcome, survival of 80%. Here, these are intermediate risk patients. So you give them some chemotherapy and surgery. Chemotherapy cycles can be 3 to 6, depending on the favorable histology or unfavorable histology. So the key message is that only there is a subset of high-risk neuroblastomas which need aggressive management. Rest of the neuroblastoma, low risk can be managed with surgery alone, and intermediate risk needs surgery plus 3 to 6 cycles of non-intensive intensive chemotherapy. This chemotherapy is not very strong. Counts don't drop that much. They don't need a lot of admissions for febrile neutropenia. So the first message I want to give you is first do no harm. So don't harm these small young children. So 1-year-old, 2-year-old, 3-year-old coming to you with neuroblastoma. If the child can be managed without chemotherapy, that's wonderful. Without radiotherapy, that's fantastic, because they are growing children. They can have growth failure, they can have infertility, they can have organ toxicity, they can get secondary cancers because of the treatment we offer. And when we know a low risk child can be cured without these toxic treatments. So, like this case, which was published in European Journal of Cancer, here, if you see, this is a non-stage 4, so like stage 3 patient with a big tumor, paravertebral mass. This was cured with surgery alone because it was NMIC non-amplified and the histology was favorable, ganglioneuroma, and the child did very well. Just incomplete resection was good enough to treat this child. Infant with stage 4 neuroblastoma, if infant doesn't have NMIC amplification, then these children do well. These are intermediate risk. You just give 3 to 6 cycles of chemotherapy, that's it, and surgery, and they can still do very well. After finishing the treatment, don't chase the MIBG. Their MIBG may still be positive. There might be uptake. As per this case report, the MIBG uptake was present for a long time, but the child remained stable after finishing treatment. So very young infants, they have very good prognosis. Even if the residual tumor is present, you just monitor them closely. Unless the tumor starts growing, you don't have to worry too much. So just give them minimal treatment. So now comes the high risk part. We again go a little bit into detail. So if it's a stage 4 patient in more than 80 months of age, that's high risk. Or any child with NMIC amplified neuroblastoma is high risk. High risk means they have high chance of relapse. Nearly half of them relapse. So here you give good, strong induction chemotherapy. So Kojak is one of the protocols we use, which has carboplatin, etoposide, vincristine, cyclophosphamide, and carboplatin. These are the 5 drugs. And usually with about 5 to 6 cycles of that, you can get good disease control. And after 3 to 4 cycles, you can do surgical resection of the tumor. And then you can offer some local radiotherapy. With this, 80% of children achieve complete remission or very good partial remission. And then you offer autologous stem cell transplant, followed by anti-GD2 therapy, and then cis-retinoic acid. But there would be a subset of patients who have progressive disease, and these children have very poor outcome. If you're not chemosensitive, you're not likely to do well. It may be a primary refractory tumor which is not responding. Here you will offer second line induction chemotherapy, and there are various agents like topotecan, there is irinotecan, there is temozolomide. These are the main drugs which can be added for the chemotherapy to reduce the tumor. And if there is some response, then autologous transplant can be done, and anti-GD2 therapy and cis-retinoic acid will be offered. So these are the various salvage regimens for resistant neuroblastoma. I won't go in the details, but topotecan, irinotecan, these are the drugs, temozolomide, etc. are there. So other new things which are happening in the resistant neuroblastoma is that MIBG or radioisotope therapy is also being explored or being used, where this radioisotope, MIBG goes and attaches to the neuroblastoma wherever it's present. And with this, you can give autologous stem cell rescue because this is myeloablative. This emits radiation and the bone marrow is damaged. So these children need an autologous rescue to tolerate MIBG. Haploidentical transplant from Germany, there is a good data of using T-cell depleted haploidentical transplant with anti-GD2 monoclonal antibody and showing survival of nearly 30 to 40% in refractory relapsed neuroblastomas. Other is immunotherapy alone can be used to get them into remission. So anti-GD2 therapy alone can be used to get them into remission, followed by transplant. So in the relapse cases which are there, close monitoring is important, because if you pick up early or it's a localized relapse, you can still offer a lot of treatment. So like this child has a relapse in the brain, and a local focal relapse can be treated with the radiotherapy, etc. If there is a tumor in the adrenal bed, again surgery can be done. Salvage options depend on what is the previous treatment the child has got, whether the child, which drugs were used. So whether you can use the same drugs or different drugs, what is the time later the relapse, long gap between the initial diagnosis and the relapse, they have better outcomes. If it's treatment, if it's relapse on treatment or soon after finishing treatment, they have poor outcomes. MIBG, radioisotope, and radiotherapy, immunotherapy, all these can be offered as I've told you previously. Just a word about CNS relapse. So in my career, I've seen around 4 to 5 children who have relapsed in the brain after autologous stem cell transplant, and they have done very poorly. But Mount Sloan Kettering group has shown that if they are managed aggressively, you can salvage brain relapses. You do a craniotomy, remove the tumor in the brain, give irinotecan IV, give craniospinal irradiation with boost to the tumor bed, give more chemotherapy, temozolomide and irinotecan, and then you can give intrathecal radioisotope, which can clear the tumor, followed by immunotherapy with anti-GD2 antibody, and then differentiation therapy with cis-retinoic acid and oral temozolomide as a maintenance. With this, they have shown few case reports where they have such big tumor in the brain with neuroblastoma relapse, they were able to cure. So I personally feel that CNS relapse is very bad and I haven't been able to save. But as for them, if you manage aggressively, we don't have these agents. We don't have radioisotope to give intrathecally, and we don't have dinutuximab monoclonal antibody. But perhaps if these things are available, we can manage these children in India as well. So newer drugs, just a word about ALK mutation should be looked at, and if it's present, then crizotinib can be added. NRAS mutation, if it's present, you can give drug for that. mTOR pathway, if it's present, everolimus, sirolimus are the drugs which can be given. So more and more targeted therapies can be offered in neuroblastoma. So if you see this neuroblastoma cell, if you see, one is we have anti-GD2 antibody, which can kill this tumor, that's available. Complement-mediated cell killing is the next thing which people are trying to develop. Myeloablative conditioning, autologous transplant, we are already using MAC. You can use NK cells after haploidentical transplant to kill the tumor. You can use chimeric antigen receptor CAR T cells which are targeting GD2. So they have been developed, although trials are going on efficacy. It is feasible. CAR T cells for neuroblastoma have been made, but the efficacy is yet to be proven. Then you have bispecific T cell engaging antibodies, BiTEs, which are targeting anti-GD2, and they are attached to the T cells. So similar to what you have Blincyto in leukemia, which is targeting CD19 in leukemia and engaged to the T cells. Similarly, you have antibody against neuroblastoma, and which can be used. So these are the new things which are coming up. Just about India's neuroblastoma story. So this was a review by Ketan Kulkarni, published in Indian Journal of Pediatrics. It showed that the data is very patchy. There are very few publications, just 4 or 5 publications from India, and the survival rates vary from 8% to 80%, but they're all small series. The largest series from PGI Chandigarh of more than 100 children showed that 50% opted for no treatment. They abandoned the treatment. They did not take the treatment. And in the remaining 50%, only about 10% or 15% survived. So overall, 8% was a survival. So I talked to Dr. Deepak Bansal, who was the first author of this study, and I said, Deepak, the survival is so poor. Why you have published this paper? So he said, Satya, there is no publication on neuroblastoma from India. So I have drawn a line, 8% survival from PGI Chandigarh. If anybody can do better, they should publish so that this line goes up. So that's the challenge he has thrown. And other centers who are treating neuroblastoma, they have to analyze their data and have to publish so that we can get better than that. But most children in India present late, stage 3 or stage 4, they are high risk and they tend to do poorly. So our outcomes are not as good as the Western countries. So this data from AIMS of 144 children, this shows that only 6 children were stage 1 and 2, and they are both they're alive and doing well. But the remaining patients were either stage 3 or stage 4. For stage 4, the last line, the CR rate was just 17% of the stage 4 patients could achieve complete remission, and overall survival was just 35%. So very poor outcome for stage 4 patients from AIMS. This study was published, I think, in 2012 or 14. This was an initiative which I had started. I asked all the centers across India to form a national neuroblastoma network and start. A registry was open to every month. New cases of neuroblastoma were being reported. We were talking online, doing a tumor board, deciding about the protocols, and trying to bring a uniformity in the care. So in this 7-month period, we had about like 9 online meetings. 64 members attended this group, and the main thing which came out was 120 new cases were reported, and 57 of them could have risk stratification, and of them 32 had NMIC tested. Of them, 8 were NMIC amplified. So NMIC was not being routinely tested. Risk stratification was not being routinely done. So that's what we need to improve our standards and care in India. 1 or 2 slides about the newer treatments which we have tried: bortezomib-based therapy, MIBG-based therapy, haploidentical transplant we have done in few children. A couple of them could achieve complete remission for relapse refractory disease. So newer treatments are required. So I'll finish here. I'll thank all my colleagues who helped me do this work and this presentation. Thank you all. I'm open to questions. Thank you.
Yeah, thank you very much, Dr. Yadav, for this wonderful presentation. You made the topic quite simple. I hope the students have benefited from your talk. I think we have certain questions in the chat box. The first question is, which substrate need chemotherapy in intermediate risk and what protocol? I think you mentioned that.
Can you repeat the question?
The first question is, which substrate needs chemotherapy in IR, intermediate risk, and what protocol?
Yeah. So once you have, all intermediate risk patients need chemotherapy. That's very clear. Only low risk patients don't need chemotherapy. So if your patient falls in intermediate risk, chemotherapy has to be given. So there is a published COG protocol in NEJM paper where it is carboplatin etoposide alternating with cycloetoposide alternating with cyclophosphamide carboplatin. So these are the agents which are cyclically rotated. Minimum 3 cycles are to be given, and that is sufficient in those who have favorable histology and a surgery is required. But if it's unfavorable histology, then you may give another 3 cycles after surgery, so total 6 cycles may be required. So that's for intermediate risk. Thank you.
Right. The next question is by Vishwajit Pai. Do you advocate use of rapid COJEC or CCG-3891 as part of induction chemo in neuroblastoma?
Absolutely. So whenever you choose a protocol, you should look at your supportive care in your center. So rapid COJEC is an aggressive protocol. If you don't have good supportive care, good blood bank, ICU, availability of residents on the floor when a child comes with high fever, so don't use rapid COJEC. It is quite an aggressive protocol. So you can use OPEC OJEC, which was the prior version of rapid COJEC, in which there is a longer gap between the chemotherapy cycles. So OJEC you give, then 3 weeks later you give OPEC. OPEC is cisplatin based. It is non-myeloablative. Your counts don't drop. You do very well. And OJEC has slight myelotoxicity, but still none of the patients need any blood products, and febrile neutropenia is very rare in OPEC OJEC. So if your center is not high-end center, use OPEC OJEC. But if you have good facilities, then rapid COJEC is better. That's what I would say. Thank you.
Right. The next question asked is about interval of monitoring and modality. How do you monitor them after the finishing with the treatment?
Yeah, so for neuroblastoma, once they have finished treatment, so I monitor them every 3 monthly. So like once in 6 months, I do a PET CT scan. And once it's alternating with, in between, I do an ultrasound and chest X-ray. So that's what I do, because PET CT is quite expensive and it has radiation, so we can't do it every 3 monthly. So I alternate with ultrasound and chest X-ray and maybe urinary catecholamines if required. And so it's every 6 months PET CT scan for at least first 2 years. And if there is no relapse, then I make it annual. And then after about 4 years, I stop screening them. Yeah.
Right. Avinash Upadhyay has asked a question. As the tumor can differentiate later in a patient in whom debulking was done, or for that matter, any patient, do we need to biopsy at progression?
So usually when we have high risk neuroblastomas, so you have done a biopsy, you're given chemotherapy, and when you remove the tumor after 3 to 4 cycles of chemotherapy, we always look at the histology. And those who have the tumor is non-viable, if the tumor has all killed, that's very good. If it has differentiated, that's very good. So tumor viability and differentiation, if that's those two things we look at, and if there is no viability and tumor has differentiated, they tend to do very well. If tumor is highly viable or a tumor hasn't differentiated, they tend to do poorly. So yes, the histopathology is important, but I would say it's not the only thing. You have to look at the overall picture. Thank you.
All right. I think when Pramod Kumar has requested, please share link for online tumor board. If people are welcome to attend that. That's a personal request for you.
I will do that. I'll mail it to you. Thank you.
Right. The next question is about stage 4 NB. 4-year stage 4 NB ischemic non-amplified BMAT positive local RT to orbit. I think it's a case probably being asked. 4 OJEC, then BMAT negative, PET good response, local RT done as surgery was not possible due to aorta involved. Another 4 OPEC given, now some residual disease. What next?
Just stop treatment. This is not high-risk neuroblastoma. Just monitor this child closely. You have done maximum treatment. If there is tumor progression, then a repeat surgery and more treatment can be offered, but maybe the child would remain stable. So we are over-treating now. So don't treat any further. Just monitor closely. The child may remain stable for many years and may be cured. Thank you.
Right. Pramod Kumar has asked a question in intermediate risk patient. If the interim analysis, the studies show no response, then how to address these patients?
So if there is no response, then they tend to become like they need to be put on a different protocol. They are no more intermediate risk and they are at very high risk of disease progression. So they are off protocol, and these patients would be candidate for more aggressive therapy like second line agents, what we use for high risk or resistant neuroblastoma. So I would switch to those kind of treatments like irinotecan based treatment or topotecan based treatment, or MIBG can be offered, or radio or monoclonal antibody can be offered depending on what is available. But definitely it needs more aggressive treatment. Thank you.
Yeah, and then if you resect these people and there's a viable tumor at resection, then how do you plan your further treatment?
No, like the treatment is still, you have to do an autologous transplant and have to give, but overall survival, it's a predictor that if the tumor is not viable, then they tend to do better. That's what I'm telling you. So, but you can't change the ultimate outcome. You will give the maximum possible treatment. So you have to do autologous transplant, you give differentiation therapy, you give radiotherapy, and you give your monoclonal antibody if it's available, and then hope for the best. And after this, if the child relapses, usually they're difficult to salvage in Indian scenario. It's almost fatal. But in high-end centers, they can, if they can go abroad, maybe they can get haploidentical transplant, maybe they can get newer CAR T cell therapy and other research clinical trials they can be recruited upon. But in the conventional sense, your treatment options finish once you relapse after autologous stem cell transplant. Thank you.
Right. Pankaj Dwivedi has asked your opinion about the use of DFMO, which has shown good outcome in phase 2 trials for relapse as well as high-risk neuroblastoma.
Yeah, I know Pankaj. So yes, Pankaj, I agree that there are a couple of papers on that. But somehow this drug hasn't become very popular, and no other center has been able to replicate or use it, or it hasn't become a big sensation. So I will wait for more data. Right now, I can't comment, but initial one or two studies were quite exciting. Thank you.
Right. Aditya has asked a question about indication for radiotherapy, except in stage 4. What are the places where you should use them?
So usually only in stage 4 patients radiotherapy is used. In stage 3 patients, we can use radiotherapy only if you have given maximum possible 6 rounds of chemotherapy and the disease is still present, then you may give radiotherapy, but it's an exceptional. In the intermediate risk COG trial, only about 4 or 5 patients were there who got local radiotherapy, but otherwise almost everyone responded to the treatment. And other is life-saving radiotherapy when its organ is being compressed. So if there is a big tumor which is pressing on some other organ and or paravertebral compression is there, then 1 or 2 fractions of radiotherapy may be given to reduce the tumor so that the limb can be saved, paraparesis can be avoided. Thank you.
Right. Rohan has asked a question about the common long-term side effects which you should monitor in these patients.
So yes, so depends on if the child was offered any chemotherapy or not. So if it was a low risk, just had surgery, then you don't have to worry too much about long-term side effects, except if the surgery was mutilating, then some immediate side effects would be visible of the surgery. If it is high risk, you have given everything. You have given autologous transplant, you have given radiotherapy, you have given intensive chemotherapy. So these children will have all the sequelae which are there with transplant. So infertility, cardiac monitoring has to be done, cardiac function, their lung has to be looked at, any pulmonary fibrosis, growth has to be done, monitoring their liver, kidney, all organs have to be monitored because all these intensive therapies have effect and the risk of second malignancy is there. So they need almost annual checkup is required every year, good general physical examination and some basic tests are required. And intermediate risk, they don't get a lot of chemotherapy, so they don't have to be monitored that aggressively, but still maybe a general checkup in them is also required. Thank you.
Right. There's one question about again the rapid Kojek versus opaque Kojek in high risk neuroblastoma. With lack of definite evidence, do you advocate use of rapid Kojek over the other two, opaque and Kojek?
So personally in my practice, I still use opaque Kojek because it is saves a lot of money. And patients can't afford. With rapid Kojek, a lot of supportive care is required, so it's very costly. And by the time you reach the stage of transplant, they don't have any money left for the transplant. So opaque Kojek, if the response is good, I find it's still doable in India. But if someone can afford, then the standard of care is rapid Kojek. That's the latest trial that has slightly better results as compared to opaque Kojek. Thank you.
I think this is the last question coming up by Aditya. Now just one more. Okay. Aditya asked a question: can differentiation therapy be given to intermediate risk when R1 resection or in case of high risk pathology, especially if the surgery done is the debulking surgery?
So in the COG trial of intermediate risk patients of nearly about, I think, more than 200 patients, so the overall survival was 92% in them, and event-free survival was close to 86%. So there were very few relapses or recurrence. So mostly they do very well. So this was without cis-retinoic acid. So a trial is required that whether by giving cis-retinoic acid we can improve this event-free survival from 86 to 90%. So it's a good research question. I think we need to do a study. Maybe in India we can do it and prove or disprove whether it gives any advantage. So yes, it's worth exploring. It's a good idea.
Right. Yeah, that's, I think, indeed a very good idea and research question.
Yes.
SV Saju has asked a question. In all stage 4 neuroblastomas, is bone marrow transplant indicated after induction and surgery?
That's a wonderful question. So recently there is a paper from PGI Chandigarh from my dear friend Dr. Deepak Bansal. So as he had published his first paper, they have improved their neuroblastoma care a lot, and they have come with more papers of current era. So they are doing autologous transplants now in PGI Chandigarh, but they are not offering it to everybody. So those patients who don't want transplant, they are offered just chemotherapy, and those who can afford transplant or want transplant, they are offered transplant. So they looked at the subset of patients who did not were not given transplant, stage 4 patients, and were given everything else like surgery, radiotherapy, and differentiation therapy. And they have shown the overall survival of 32% and event-free survival of 25%, which is similar to what Americans have shown 30 years back. So yeah, if you are not doing transplant and doing everything else, so I think you can still save around 25% of the patients. So that's not a very bad idea. You can still do that. Yeah, thank you.
And the last question, particularly applicable to current era, how to address stage 4 in COVID era? Is there any change in protocol in rapid COJEC or OPEC, especially hospitalization issues?
Absolutely great question. So with COVID, things are changing very fast. So we have to be very flexible. We have to look at our hospital, our resources, how many patients of COVID are present in our hospital or how many are coming positive. So one is screen all the patients if possible before giving intensive chemotherapy. So as a practice in my center, I do COVID test before giving a big block of chemotherapy. Patient should be negative. And then even in the intensive chemotherapy, I look at the disease. If it's very aggressive disease, where if you reduce the intensity of chemotherapy, the chances of relapse are high, I tend to give them full dose. But if the disease is not very aggressive, I can cut down on the dose or reduce the intensity, I might do that. So neuroblastoma, you have an option of OPEC OJEC, which is better tolerated as compared to COJEC. So in COVID era, I would tend to go towards something which is better tolerated, where blood products are not required because your blood bank will have shortage of blood, platelets, etc. So I would go towards slightly less intensive, but still which is well published. There is data, so you are not doing something wrong, but it is slightly less resource constraints would be there in that. So I would change the protocol a little bit in this COVID era. Thank you.
So I think that gets us to the end of today's session. Thank you very much, Dr. Satya, for being with us for the wonderful lecture and a patient question and answer session. I'm sure the students must have enjoyed and benefited from this wonderful interaction. Thank you very much, friends, for your patient listening to. We will meet next week on Tuesday with another expert and a new topic. Till then,
thank you so much.
Thank you very much and good night.
Good night. Bye-bye.